Hi, I'm Simon Bartold from www.bartoldbiomechanics.com, and this is Langer UK TV. Today I'm going to talk to you about a very important condition that affects maybe 1 in 10 people. It's especially prevalent in runners. It's kind of like the artist formerly known as Prince. We used to call this plantar fasciitis. We now call it plantar heel pain, and I'll explain why that is to you in just a moment. To start with, I want to run through some anatomy with you because this is an incredibly important structure. It's basically the structure that maintains the integrity of the arch of the foot. It's a very broad fan-shaped ligament that runs from the heel and then fans out across the metatarsal heads here. And you can understand that because it's such a strong fibrous band, it helps to maintain the arch shape of the foot. It's also incredibly important in gait because as you move through the gait cycle and your heel lifts off the ground, the plantar fascia develops tension, and it means that the foot can become a very effective lever for push-off. You can also understand that it is subjected to an enormous amount of stress, so it is quite susceptible to injury. Normally we see the condition present just around this sort of region here, so right at the start of the arch area here. This is where the plantar fascia inserts into the bone. Characterized by point tenderness, so we can get a finger, we can point right on the spot. The runner or the athlete will normally identify quite strongly with pain, so it really does hurt. The other key feature of plantar heel pain is that it's extremely sore first thing in the morning when you get out of bed. We call this first step pain. Also, if you've been sitting for a long time, you get up, it tends to be very painful when you take that first step. Now, I've already said that we don't tend to call it plantar fasciitis anymore. We tend to give it a more generic name, plantar heel pain. Why do we do that? The reason we do that is that when we actually go in here and look at this with biopsy, in other words, if we've done a little surgery and we're trying to identify the condition, we don't see any inflammatory markers. In other words, no signs of inflammation in the area. Now, any condition that has itis on it means it's inflamed. So we can't call it plantar fasciitis because it's not inflamed. Is that splitting hairs? Does it really matter? Well, it really does matter because it dictates the way you treat it. Now, obviously, if it's inflammation, you'll try to use anti-inflammatory protocols, maybe medication, maybe ice, perhaps even an injection of cortisone. But we see that as being perhaps not the right way to go because there is no inflammation. So we've got to try to figure out what else is going on. So what is going on here? Well, traditionally we've had this, I suppose, mental image that the plantar fascia is actually ripping away from the heel bone. And there are horrible graphics out there online that you can see with showing this where the whole thing's ripping away from the bone. In fact, that's not the case at all. There is, I think, probably not a great deal of componentry in terms of tension tearing of the plantar fascia. What we understand now is that this fatty tissue here, this is the plantar heel pad here, the fatty tissue under the heel, very important to protect the underlying structures, the bone. There's nerve complexes here, there's also the plantar fascia, and there's muscles there. This fatty tissue protects all of those structures. What we think is that there's probably some compromise to this fatty tissue. Maybe it changes its material properties so that it doesn't actually allow shock attenuation as well. And it's traumatizing the insertion of the plantar fascia. So we tend to get damage to the plantar fascia in compression rather than in tension. And that's a very important point. So we think that side of the injury is very, very important. And that also is quite critical in terms of how we treat the condition. There are a number of things that we might be interested in looking at here. So in terms of assessment, things like the range of motion into dorsiflexion, very important. If that's restricted, it tends to put increased load on the plantar fascia. Footwear is also quite critical. We'll be talking about that later on today. And also things like biomechanical profile, assessing the gait is really very important. I think also of great relevance here is just having a look at how the first metatarsophalangeal joint functions. If this joint is not functioning properly, again, it changes the load on the plantar fascia, and this can be a really important part of the development of the syndrome. So we've covered what it is, we've looked at where it is, we've talked about the function of the plantar fascia in gait. In terms of treatment, what are our options here? There are many different options you can use, and I think it's very important to perhaps split this condition into either an acute phase or a chronic phase because the treatments differ depending on whether it is acute or chronic. In the acute phase, which means, let's say, maybe the first 4 weeks, the condition is developed, my philosophy is basically you throw everything, including the kitchen sink, at it. So I'd be looking at things like ice, not so much as an anti-inflammatory protocol, but because it has really excellent anaesthetic qualities, so it really does help to control the pain. I get people to get a plastic bottle, fill it with water, freeze it, and roll their foot over it. You can do a similar thing without the cold component with a tennis ball, and you can really focus in on the area of pain. That is quite good, I think, in terms of dissipating any fluid build-up here. It's also quite good in terms of stressing the plantar fascia and helping the collagen fibres, the building blocks of the fascia, to realign properly. Stretching the actual plantar fascia itself manually is one of the, I suppose, proven techniques in the scientific literature. This is a very simple technique. For Rosie, it simply means grabbing her big toe, bringing it back until the plantar fascia is on stretch, and you can probably see that the plantar fascia is standing a bit proud now, so it's actually popped out. You hold that stretch for a count of 30, it'll start to relax a bit, crank it up a bit more for an additional count of 30, and you can do that 5 times a day. In fact, you really can't do this too much. Now, there have now been about 4 randomised controlled trials that have looked at this, and they've all shown that this is a very effective way of helping to realign the collagen fibres and to help settle down the pain of plantar heel pain. I also look at stretching protocols, so if we've got any sort of restriction in ankle joint dorsiflexion, I'd certainly be trying to improve that if I possibly can. As with everything, you're going to hear this as a recurring theme with these talks. I think looking proximally is really important. So whenever you have pain in the heel or pain in the foot generally, there's a real temptation to just focus on the foot. I think that global assessment is really, really important. So Rosie, as an exercise scientist, would agree with this, that to look at structures more proximally, especially during gait, is incredibly important, because if these structures are not functioning properly, these structures are not functioning properly either. So we tend to look distally, proximally, and then figure out what's going on in the middle. That's a really good way to assess your athletes. So definitely, as a part of your gait analysis, have a look and see what's going on in terms of more proximal control. Try to get an understanding of whether the muscles are firing correctly and at the correct time, because that will have a real impact on what's going on at the distal level. I also use strapping techniques for plantar heel pain, very, very effective in the short term. I have high expectations of good results with that. If I get a result with the strapping I use, which is very specific, and it's really designed to invert the rear foot and evert the forefoot, so to try to take some load off the plantar fascia, then I usually will think about proceeding to some sort of orthotic device. Now, there are many, many choices, and again, we're going to talk about that a bit later on here, from quality prefab devices to bespoke cast orthotics. The literature tells us that there's not a lot of difference in their efficacy, so I certainly would recommend that we think about using a prefab or an over-the-shelf device, something like the bioorthotic, which I'll show you a bit later, as our sort of primary treatment protocol if you're going to be using an orthotic device. That's the acute stage of plantar heel pain. The chronic version is something that's been around maybe 6 months or more. Perhaps the athlete has had lots of different treatment, the things I've described, maybe still having heel pain. We're dealing with a totally different beast there, and there is now some good evidence to use things like extracorporeal shockwave therapy. It doesn't work in the acute stage. It does tend to work quite well in the chronic phase, so that is something that I might be considering. As with any sports injury, it's very important to titrate your results. So you've got to be in the mindset that you're testing and retesting, making sure that you've set goals for your therapy. If you haven't met those goals, you've got to rethink your strategy. And if you get to a point where you're just not getting a result, the best bit of advice I could give you is refer it on, get other people involved. You should be doing that earlier rather than later, of course. But just make sure that you're not afraid to let go of the issue and get other people involved if you're just not getting the results that you need. Okay, that's a snapshot of plantar heel pain. Hopefully that information has been useful for you. Thanks to Rosie here to help us out, and we'll move on to our next condition.